We ready, go.
Good afternoon, everyone. Welcome again to our seasonal series on cardiovascular topics. I hope you have been enjoying so far the presentations that we have been providing to all of you. And I welcome your comments and your feedback. And please invite any friends and family that may be interested in these topics. As you know, we're doing this every other Friday at 12. And if you have no opportunity of watching the transmission live, remember that you can always log in and search our YouTube channel, where this presentation will be permanently saved and stored for future viewing. Today is a great pleasure to have Ythan Goldberg, a member of our faculty, who has a brilliant career. He's an assistant professor of medicine at the Albert Einstein College of Medicine. He's a director of the non-invasive cardiology program at the Weiler campus. He's also part of the structural heart team at Montefiore and co-investigator or principal investigator of many of the investigational valve device trials that we are conducting at Montefiore. Dr. Goldberg completed his undergraduate studies at Cornell before he graduated from medical school at Rutgers University in Newark. He has been at Montefiore since then, starting in 2001 as an internal medicine resident, completing his fellowship in cardiovascular disease and joining our faculty in 2007. Dr. Goldberg's clinical interests include echocardiography and valvular heart disease. His research interests include cardiac imaging, hemodynamics, and valvular heart disease. He has authored numerous peer-reviewed manuscripts and review articles and has spoken at regional and national conferences. He has received multiple teaching awards from the Cardiology Fellowship Program. He's board certified in cardiovascular disease and adult comprehensive echocardiography. He will be talking to us today about aortic stenosis and about a guideline-based approach to the evaluation and management of this very relevant topic in cardiovascular medicine. Ythan, welcome.
Thank you very much, Mario, for the introduction, and thank you for the opportunity to present to everyone here. Aortic stenosis is one disease from one valve, and it seems like it should be straightforward, but in putting this together, made me appreciate exactly, the complexity and all the nuances that go into both the diagnosis and appropriate treatment. And while the topic is a guidelines-based approach, guidelines obviously don't cover all aspects, so we'll have to stray beyond the guidelines at certain points during the talk. And so I wanted to start with just a review of the normal aortic valve anatomy. There's three cusps. We have the right semilunar cusp, the left semilunar cusp, and the posterior or non-coronary cusp. And the anatomy of each leaflet is, they're covered in, lined with endothelium, and inside there's a fibrosa layer, which gives the stiffness and structure and integrity to the valve. And then there's also a spongiosa layer, and that allows for cushioning to reduce the damage from the hemodynamic forces during systole. The three major types of native aortic stenosis include rheumatic disease, bicuspid valve, which is a congenital malformation, and fibrocalcific disease. Rheumatic disease overall affects 33 million people globally, and 20 to 30% of those will have involvement of their aortic valve. But it's notable that isolated aortic stenosis, meaning aortic stenosis without mitral valve disease, is very rare, and it's arguable whether it exists at all. We'll go into a little bit about bicuspid valves, and the bulk of the talk will be regarding fibrocalcific valve disease. Just a little about the burden of rheumatic heart disease. And as you can see in the high social development areas of the world, it's low. And in the less developed areas, it's high. But what's interesting is that there is not a clear correlation between the prevalence and where the numbers are increasing. So as you can see, that there are some countries in Europe where incidence is actually increasing. And this is all part of the global immigration patterns, from less developed to higher developed socioeconomic areas. So, the main point is that even in the higher socially developed areas, we still need to be vigilant and consider rheumatic heart disease as a diagnosis. And this shows across the last 20 years or so, overall rheumatic heart disease is declining, and fibrocalcific disease is increasing globally. Some points about bicuspid aortic valve. It's the most common heart disease at birth. Reported rates are usually 1 to 2%. More common in males than females. There is some familial clustering, and the incidence can be as high as 10% in some families. For those under age 70 with severe aortic stenosis, bicuspid valve make up the majority of cases. And up to half of patients with bicuspid aortic valve also have pathology involving their aorta, whether that's coarctation or aneurysm in the ascending aorta. And there's a classification system that was devised that basically, depending on the number of fused cusps or raphes, which is what this line represents here, they're divided into these different types. So we have type 0, which can have different orientations of this orifice with 2 commissural points and no raphes. Type 1 has 1 raphe, okay, which, for example, you can see here. This is a fusion between the right and left coronary cusps. And then this type 2, where you actually have 2 raphes that are fused. And these are the ones that are actually associated more with aortic pathology. So there is some prognostic implications of this classification system. Now, calcific aortic valve disease, as of 2017, 12.6 million cases. Over 100,000 deaths are attributed to it each year, and the mortality has been increasing over the last 20 years. This shows the burden of calcific aortic valve disease, and this is in contrast to the rheumatic disease prevalence, where rheumatic disease is low. The burden of calcific aortic valve disease tends to be high. And the implications for this in terms of the daily adjusted life years is increased dramatically since 1990 in in the U.S., Europe, and parts of Asia. So the financial cost, the human cost to this disease is rapidly expanding. A little bit about the pathogenesis of calcific aortic stenosis. It's very similar to the vascular damage that occurs in coronary artery disease. Okay, it starts with endothelial injury. You have infiltration of inflammatory cells and deposition of lipids. This releases inflammatory mediators, and the undifferentiated valve interstitial cells undergo osteoblastic differentiation and or apoptosis, and both of these pathways lead to calcium deposition. The osteoblasts first lay down a collagen scaffold, but these apoptotic bodies are nitises for calcium deposition in and of themselves. So these the calcium precipitates then further lead to shear stress and damage along the endothelium, and this leads to a cycle of injury, inflammation, calcification, and then eventually sclerosis and stenosis. So aortic stenosis is usually diagnosed either by echocardiogram performed for another reason, or a murmur on physical exam. And some of the features of severe aortic stenosis, although not necessarily specific, include a high-grade late peaking systolic murmur that radiates to the carotid arteries, a delayed and diminished carotid upstroke, otherwise known as pulsus tardus et parvis, and a single or paradoxically split S2. And normally, the pulmonic valve occurs later in inspiration than in expiration. But with the aortic valve, in severe aortic stenosis, it closes relatively later. So it makes it, you actually get less of a split during inspiration as the pulmonic valve closes later. And this is probably one of the more specific signs on physical exam. So the prognosis for severe symptomatic aortic stenosis is very poor, and this has been known for over 50 years. What is interesting is that back then, when this was described, the average age of onset was around 60 years of age. And depending on which type of symptom you had, whether it was angina, syncope, or heart failure was the worst in terms of average survival and time to death. But since then, severe aortic stenosis is occurring generally later in age. So we are seeing patients in their 80s and in their 90s, and the longer latent period before the onset of symptoms. What about asymptomatic aortic stenosis? Well, prognosis depends heavily on the aortic valve velocity that's noted on echocardiogram. And this correlates with severity, with generally greater than 4 meters per second. Peak aortic stenosis velocity is considered severe aortic stenosis. So Valve disease and heart failure and a lot of cardiac diseases now are grouped into stages A through D. Aortic stenosis is no different. First stage is stage A, which are people who are at risk of aortic stenosis, including those with bicuspid valve and those with sclerotic valves that are not necessarily stenotic. Stage B are those who have less than severe aortic stenosis as defined by their aortic valve velocities or mean aortic valve gradient. They may have diastolic dysfunction, but generally they have normal systolic left ventricular function. Anything C and beyond are those who have severe aortic stenosis, and the stage C is divided into those who are asymptomatic with normal systolic function, and those who are asymptomatic with reduced LV function. And then stage D is the most tricky because we have those who have high gradient symptomatic severe aortic stenosis. We have those who have reduced flow, and those can either have a normal ejection fraction, the D3, or they can have reduced ejection fraction, the D2. So D2 is called low flow, low gradient with reduced EF. D3 is low flow, low gradient with normal EF. And the evaluation, the follow-up, and the management for these patients all differ in some way or another. So these are the criteria to keep in mind for severe aortic stenosis: peak velocity greater than 4 meters per second, mean gradient greater than 40, or an aortic valve area of less than 1 centimeter square. Symptoms and reduced LV dysfunction amplify the poor prognosis. So when we perform echocardiogram, we have several things to keep in mind. First is anatomic and identifying the number of leaflets. And then besides systolic dysfunction and associated other pathologies in the heart and the aorta, we're focused on the hemodynamic severity. Again, looking at gradients, velocities, using the continuity equation to determine the aortic valve area. And that's pretty much it here. Okay, so the continuity equation, basically what it says is the amount of blood that is flowing in a given systolic period, the amount of blood that goes across the LV outflow tract has to be the same as that crossing the aortic valve. And we can use the certain measurements through Doppler and 2D echocardiography to calculate the aortic valve area. Okay, so we make assumptions about the area of the LV outflow tract, namely that it's circular, but we'll see that that's not necessarily the case. But if you can measure the velocity at that same location where you measure the area of the LV outflow tract, and we can measure the Doppler envelope across the aortic valve using continuous wave, then we can solve for the aortic valve area. There are numerous pitfalls to this method. Okay, it requires our Doppler to be directly aligned with the direction of flow as it crosses the aortic valve. So down here you can see different locations for placing the transducer. And to the right here, we can see, wish I would stop doing that, but we have a mean gradient measured from the apical window of 34 millimeters mercury, but from the right parasternal window, it's double that mean gradient. Okay, so these are images that your echocardiographers need to be aware of in order to most accurately determine the aortic valve gradient. So we have Doppler alignment, we have LVOT Doppler placement, and so for example, over here, if I am placing my pulse wave Doppler too far from the aortic valve and towards the left ventricle, this cross-sectional area may be larger than what would be here closer to the valve. And then you're going to get a lower Doppler VTI, and you're going to underestimate the valve area. Likewise, using the diameter measurement, that can lead to underestimation or overestimation, depending on the true shape of the LV outflow tract. And as you can see here, what we would be measuring in terms of the diameter is on the red line, whereas the yellow line is in the medial lateral plane, and that's a larger diameter. So we have an elliptical shape, and we would be underestimating the valve area here if we just looked at the diameter from the long axis view of the outflow tract. And then there's a phenomenon called pressure recovery, which can overestimate the gradient on echo relative to cath. So what happens here when in patient 1 on the left, where there is a high degree of pressure recovery, beyond the aortic valve, there's laminar flow, and this velocity is eventually, when the blood slows down higher in the ascending aorta, this energy, kinetic energy, is returned as the blood slows down to potential energy, which is otherwise known as pressure. So when we measure on echo the velocities and indirectly pressure, we're measuring at the peak, the gradient, okay, which is closer to the aortic valve. But on catheter, they can measure simultaneously in the LV outflow tract, and they can measure distally to where this pressure recovery occurs. So this more accurately reflects the amount of work that the ventricle has to perform when it's ejecting across a stenotic valve. And this pressure recovery phenomena is more likely to occur in smaller aortic roots than it is in larger aortic roots, because the velocity is converted back to pressure much more quickly in larger roots. So something to keep in mind, particularly when we have smaller patients and smaller aortic roots. So we also use Dobutamine stress echo, particularly in this low gradient, low flow with low ejection fraction, the D2 group of severe aortic stenosis. And the reason why is that there's a flow dependency to the valve opening, and it's important to be able to differentiate whether the aortic valve is not opening because the stroke volume across it is low and not able to open it completely, or is it because the aortic valve is truly severely stenosed and it's not going to open even if the stroke volume were to improve by increasing contractility from dobutamine. The other value with dobutamine stress echo is to determine whether the LV has any contractile reserve. So if they were to intervene and replace the valve, would there likely to be any improvement in the left ventricular function? So the criteria for performing a dobutamine stress echo, you need to have a heavily calcific valve that demonstrates reduced systolic opening. LV ejection fraction has to be reduced. And generally, we're looking for a stroke volume, which can be measured from Doppler, that's indexed to the valve to the body surface area of under 35 millimeters per meter squared. The calculated valve area should be less than a 1 at baseline, and these patients would have gradients and velocities that do not meet the criteria for severe aortic stenosis otherwise. And this shows example of 2 patients who underwent dobutamine stress echo. And in panel A, the resting gradient was about 3.2 meters per second, went up to 4 meters per second with dobutamine. The valve area went from 0.82, but actually, by calculation went down to 0.73. But the bottom line is that it did not open further despite the increase in gradient and an increase in stroke volume. In panel B, also the resting velocity was a little over 3, with which increased to about 4 with dobutamine. But here, the valve area went from 0.75 up to 0.9. So there was some improvement. And this patient likely had pseudostenosis, or flow-dependent valve area. What about exercise stress echo? Well, this can be used in patients who, where it's unclear whether they're symptomatic or not. That's probably where it has the most value. So asymptomatic patients who have high gradients. And what we're looking for are symptoms such as angina, dyspnea, dizziness. Hopefully they don't syncopize. Any arrhythmias could portend, the risk of sudden death with severe aortic stenosis. Looking for abnormal hemodynamic response. So with exercise, blood pressure should increase. Ischemic EKG changes are actually not specific, so that's something to keep in mind for the patients who have stress tests. If they have severe aortic stenosis and they develop ST depressions, about 80% of patients will have such ST depressions, and it doesn't necessarily mean that they have a worse prognosis. So it's mostly the other features in terms of symptoms and the hemodynamic response that we're looking for. So what's the prognostic value of performing stress echo in asymptomatic patients? Well, you can see that those who had abnormal tests, were at high risk of having a cardiovascular event or requiring aortic valve replacement over the following 3 years. And this actually was an even higher prognostic value than the valve area itself. Now, when to perform surveillance echo in patients with aortic stenosis, it generally depends on what is the the severity of the aortic stenosis at the time of initial diagnosis. So for those who are deemed to have mild aortic stenosis, 3 to 5 years would be reasonable. Those with moderate aortic stenosis, every 1 to 2 years. And then once you get into the severe range, every 6 to 12 months. And this is assuming that there's no symptoms or other reason to suspect that the aortic stenosis might be worsening, in which case you would want to get an echocardiogram sooner. So the role of cardiac catheterization in the diagnosis of aortic stenosis, obviously it's important to determine coronary anatomy and severity of coronary disease when planning for aortic valve intervention. But in terms of the diagnostic value of cardiac catheterization, it's generally performed when the non-invasive data is either non-diagnostic or if there's a discrepancy between the echo severity and the clinical exam or description of symptoms. The cardiac catheterization method for valve area uses something called the Gorlin equation, which is on the left. Uses cardiac output, usually by Fick. I need to know the heart rate, calculation of the systolic ejection period, and the mean gradient. And it's while it looks very different, there are components that are analogous to the continuity equation. Okay, this area times VTI gives us stroke volume by echo, and stroke volume on cath is the cardiac output divided by the heart rate. And the VTI of the aortic valve, which is in units of length, is analogous to square root of mean gradient, which is like a velocity unit multiplied by a time unit, which gives us a length unit. However, there are significant differences generally conceptually between the cardiac cath valve area and the echo valve area, which I think I will get to later on. So generally, the Gorlin equation and continuity equation, there's a good relationship, but the valve area by echo tends to be on average slightly less than the valve area by cardiac cath. And what this shows is both are flow dependent, which is why dobutamine echo can be useful. So, the Gorlin equation is not immune to low flow states in terms of underestimating valve area. A doubling of the flow across the valve by the Gorlin equation leads to about a 28% increase in calculated valve area. Okay, so this is for the same patient at different flow rates. And by echo, it's slightly less flow dependent, but doubling leads to a 22% increase in valve area. What about CT scan? Well, we can use the Agassiz units, which is a calcium score system, which was originally designed for coronary artery disease, but it has been used in evaluation of aortic stenosis. So if you have less than 700 Agatston units, that pretty much excludes the severity severe aortic stenosis. Whereas if you have a score greater than 2,000, very likely to have severe aortic stenosis. So this can be helpful when there's still questions remaining after conflicting data between echo and cardiac cath. But the sweet spot for the calcium score seems to be at 1651, which gives you an 80% sensitivity and 87% specificity for diagnosing severe aortic stenosis. It made, when I was thinking about CAT scan and why can't you just trace the area of the valve and on CAT scan, and wouldn't that be most accurate? But the problem with this is that it doesn't give any hemodynamic information, and the geometric valve area, which can also be done on echo, and the geometric valve area is actually what is calculated by the Gorlin equation, is different than on echo, which is an effective orifice area. So it takes the effective orifice area has a variable concordance with geometric orifice area. Part of it is the pressure recovery aortic root, but part of it is also the geometry of the aortic valve itself. So are the leaflets coplanar, or are they more funnel shaped? Those things can affect the effective orifice area measure calculation versus the geometric. And it turns out for prognostic purposes, the effective orifice area is what we've been relying on, and what the studies have shown the prognostic value for. So and the other aspect of a freeze point in systole to trace the area is that that's only occurring at one time point during systole. The valve area and shape will change over time throughout the course of systole. So the advantage of echo and the effective orifice area is that it takes the entire systolic period into account in determining that value. But CT scan is playing a crucial role in pre-procedural planning for TAVR. So it provides a lot of information about the anatomical structures, about sizing, for the correct size valve, and risk for coronary artery obstruction as well. So medical management of aortic stenosis is fairly simple, because there's not really that much that can be done in terms of long-term prognosis. But the most important thing that I think we can do for these patients is to treat the hypertension. For patients who come in with acute heart failure, vasodilator therapy to decrease the blood pressure, can be employed, but it should be performed with invasive hemodynamic monitoring. But in truth, it is often what these patients need, despite the risk of ischemia. But these patients are extremely high risk, and they should really be expedited in terms of treatment. Statins, which show a lot of benefit in coronary artery disease, primary, secondary prevention, unfortunately have not been shown to halt the progression of aortic stenosis. And this data was demonstrated in the SEAS trial back in 2008, and you can see where they gave statin and ezetimibe to patients. They markedly lowered LDL to under 70, but there was no significant change in aortic valve velocity. Cardiovascular events were unchanged with the exception of ischemic cardiovascular events, namely, the benefit with coronary disease. And the thought is that, once these, the nidus of calcification forms, that these calcifications can't be reversed, and then the cycle of damage and osteoblast formation can't really be stopped with statins. However, early lifestyle changes, potentially early statin use before the development of aortic valve sclerosis could, in the long term, prevent aortic stenosis from occurring. So this slide shows the recommendations from the guidelines regarding who should go for aortic valve replacement. And it's a little bit busy, but try to simplify this. So if you have severe aortic stenosis and you're symptomatic, you need surgery. If you're asymptomatic, but you have reduced ejection fraction, or if you're going for another cardiac surgery, you should get aortic valve replacement. If you have what's deemed very severe aortic stenosis, meaning your peak velocity is over 5 or mean gradient over 60, these patients are at high risk and will likely benefit from surgery. Likewise, for asymptomatic patients who have abnormal exercise stress test, they would also benefit from surgery. For those who don't meet the criteria for a severe aortic stenosis based on the hemodynamics on echo, symptomatic patients who have low ejection fraction and who have demonstrated true severe aortic stenosis with dobutamine stress should undergo surgery. Those who have valve area less than 1 and a normal ejection fraction, these patients generally have small LV cavities, which is why, despite the normal ejection fraction, their overall stroke volume may be reduced. These patients should only go for surgery if it's deemed that the aortic stenosis is likely to be cause of their symptoms. And then for asymptomatic patients who don't meet criteria for severe aortic stenosis, only if they're going for other cardiac surgery would aortic valve replacement be indicated. So the bottom line, the questions that we want to ask is the aortic stenosis definitely severe? Is the patient symptomatic? Is the ejection fraction normal or reduced? And does the patient need any other cardiac surgery? If the answer to 2 of these is yes, then they probably should have aortic valve replacement. Just a little bit about the very severe group, and with asymptomatic very severe aortic stenosis. The all-cause death and cardiac death in those who had surgery over 6 years was, they had excellent outcomes, whereas conventional, which is the wait and see, they had steadily declined each year. For some reason, which was not explained in this paper, cardiac mortality free survival was much lower in males than in females. And that gender difference certainly warrants more investigation, but this could be related to coronary disease events. And then this study looked at what they looked at patients who had peak velocity between 4.5 and 5 versus those who had greater than 5. And basically they found that the higher the velocity, the higher your risk. Just a note about pregnancy and aortic stenosis, because this comes up. This is not in the guidelines, but there is guidance for how to manage aortic stenosis. And from a global registry on patients with cardiac disease, they identified 62 patients with moderate aortic stenosis, 34 patients with severe aortic stenosis. None of the mothers died. Severe aortic stenosis was associated with higher rate of hospitalization overall. Heart failure was more common in those patients who were symptomatic prior to becoming pregnant. And in terms of risk to the baby, severe aortic stenosis was associated with a low birth weight. So the general guidance for patients with aortic stenosis and in pregnancy, if there are no symptoms and the ejection fraction is normal, they're generally considered low risk for delivery complications. We would advise those who have severe aortic stenosis, who do have symptoms, to not become pregnant. Okay. However, those with severe aortic stenosis who don't have symptoms and who have a normal LV function, normal functional status, and no other evidence of heart failure, that those mothers also do well. For those who are pregnant, whether they're symptomatic or it's too late at that point once they're pregnant, but the medical therapy approach is generally successful with balloon valvuloplasty employed as a last resort, and aortic valve replacement should strongly be considered after delivery. Now, the question these days is whether there's surgical versus TAVR, and I'm getting a message that I should wrap this up so that we can have some questions. So I was going to go through the partner trial series. So I'll try to just run through this quickly. The first partner trial was in inoperable patients, looking at comparing TAVR to medical therapy. Bottom line, it was, with early operator experience and early generation valves, TAVR was beneficial in these patients. In those with high risk compared to surgery, TAVR was non-inferior. Partner 2 looked at intermediate risk. So these were patients with STS 30-day mortality of 4 to 8%. These patients did well, comparably to surgery, and there was some evidence that TAVR through the transfemoral approach was better. And now partner 3, which looked at TAVR in low surgical risk patients, STS score less than 4%, using the newer SAPIEN 3 valve, showed TAVR to be superior to surgery in terms of combined death, stroke, and rehospitalization. So here are the guidelines for SAVR versus TAVR. These are from 2017. So, at the time of this, which was before the partner 3, low surgical risk was recommended for SAVR, but at the next guideline update, I expect that will change. Intermediate risk could be SAVR or TAVR, and same for high surgical risk. And those who are prohibited surgical risk, who have severe aortic stenosis, should undergo TAVR. So just the future directions of where we're going with aortic stenosis. So early detection and prevention, I think, need to be an area of focus, because we don't really have good ways for treating that. Multimodality imaging, particularly with CT scan, is going to become more important with transcatheter procedures. Improved operator experience and TAVR designs will reduce complications from TAVR, hopefully. The long-term durability of TAVR is still unknown, but appears to be equivalent to surgical valves up to 5 to 10 years. And then question is there a role for TAVR in truly asymptomatic patients with severe aortic stenosis? We will possibly be conducting a study here, a multi-center study, looking to answer that question. Please feel free to contact Structural Heart Program if you have any questions, or if you have any referrals for aortic stenosis or for any other valve disease. And hopefully I've left enough time for questions.
Thank you, Ythan, for a great and very comprehensive presentation. I had a couple of questions here, and then I'll go over questions from the audience. Please use either the Q&A or the chat function in Zoom. So the first question I have to you, Ythan, it's very common. I've seen that these patients with aortic stenosis who are still asymptomatic, they have uncontrolled hypertension. Do you have any particular restriction about what type of medications to use to treat hypertension in these patients?
I would say generally not. The one, I guess I may be a little bit more hesitant to give diuretic in these patients, but vasodilators, especially in those who don't have, very severe with coronary ischemia, vasodilators are generally been shown to be safe. That include, including the ACE/ARB and calcium blocker class. So, generally following the guidelines for treating hypertension works fine in aortic stenosis patients.
Question for the audience here from Said. Any role for calcium score in diagnosing low flow, low gradient severe AS, or is it only in the paradoxical low flow, low gradient patients?
So I think any low flow, low gradient patient, regardless of whether they're normal EF or reduced EF, I think the calcium score can be useful. And we find both in just qualitatively on echo, as well as, patients who do get CAT scans, that the heavier the calcification, the more likely that the stenosis is going to be severe rather than, pseudo-severe.
There's another question here from Dignatius here. What is the role of using the dimensionless index along with other parameters to evaluate the severity of AS?
The dimensionless index is basically just the ratio of velocity of the LV outflow tract to the aortic valve velocity. The benefit is that it removes the error of measuring the LV outflow tract. So I think its greatest value, assuming that there's no change to the shape or contour of the LV outflow tract, greatest value is following serially whether there's progression and whether the observed changes in valve area over time, if they are just a matter of change in stroke volume, at the time of one echo versus the following echo. So I think within the same patient and following longitudinally, dimensionless index can be very good. But in terms of using criteria that apply to patients across the board, could be problematic.
So Ythan, I have a few cases of elderly patients with severe aortic stenosis who are fairly stable, asymptomatic, and suddenly they present with gastrointestinal bleeding, low hemoglobin, repeat the echo, the gradients that were stable within, let's say, a peak of 40, 50 millimeters of mercury. Suddenly they're measured at 80, 100 millimeters of mercury. And obviously in that setting, they're having symptoms. Have you seen that?
Oh, certainly. And especially in elderly patients with severe aortic stenosis and they develop GI bleeding, as when the aortic stenosis gets severe and the valve velocities get high, they can shear the blood cells, release von Willebrand factor, and this can cause GI bleeding. And certainly, that's a sign that despite the bleeding complications, those patients are not going to stop bleeding. They're still going to have higher risk, until they get valve replacement. So, it's not a classic sign, but I believe that it's definitely, from the standpoint of aortic valve severity and progression, that it is important that the valve gets replaced at that time.
So maybe one more question here. When do you recommend mechanical valve rather than the biological valve or a TAVR?
A mechanical valve, well, patients with fibrocalcific aortic valve disease, which is what we're seeing primarily, these are older patients, and mechanical valve is generally not recommended. The requirement for lifelong anticoagulation is certainly a problem, as well as these patients will almost certainly not be able to get any, a second surgery if something were to happen to that valve. So putting in a bioprosthetic valve or a TAVR allows for, a second or third transcatheter intervention in the future. For younger patients who have bicuspid valve or with rheumatic valve disease, mechanical valve, could be an option.
So there is a Dr. Latif, I don't know if you know him, who's asking a question. So that if we are not going to use mechanical valves, so we're going to put biological valves. Why not to do TAVR on everyone?
Well, that certainly we're heading in that direction. It may be that unless, in the future that, again, as the operator experience improves, as the design of the valves improve, that TAVR will be the first choice across the board. Having said that, there are a lot of details and things that need to be checked to ensure that placing a TAVR valve is safe in terms of obstruction of coronaries, risk for paravalvular leak, and the vascular access as well. So I think there will always be a role for bioprosthetic surgical valve, but it may be the secondary choice and not the primary choice.
Well, I think we are now at our 1 p.m. Mark. I want to thank you, Ythan, for again giving a great presentation, very comprehensive. I think it's been very informative to all of us. I want to say thank you to the audience for attending these lectures, and encourage you to continue to attend them. And if any of your colleagues did not have the chance, again, this will be saved in our YouTube channel. Be aware that we will continue in 2 weeks with this series, and I hope you continue to enjoy. And if you have any suggestion for future topics, please don't hesitate to send us an email. Have a good weekend, everyone.
Thank you.